morning everyone. So today we are going to talk about palmar spaces. All of you have finished the dissection of the palm. All of you have seen the various fascia, the different muscles, the tendons, the nerves, the arteries that are present in the palm. Now we will talk about the palmar spaces and their importance. So palmar spaces are also known as fascial spaces of the palm. Under normal conditions, they are not well defined. That is why you didn't see it during dissection. They become apparent only if there is collection of pus. So, if there is any pathology of these spaces become important. So, only if you know what these spaces are, will you be able to provide treatment. Now, before we go to the palmar spaces, we will have a brief look on the deep fascia of the palm. So, you know the skin that is covering the palm. Beneath that, you have the superficial fascia, and beneath that, you have the deep fascia. Now, the deep fascia in the palm is having some modifications. These are, first is the flexor retinaculum. Next, you have the palmar aponeurosis. And thirdly, the fibrous flexor sheaths in the fingers. So, three modifications of the deep fascia of the palm that you should be aware of are the flexor retinaculum, the palmar aponeurosis, and the fibrous flexor sheaths in the fingers. The flexor retinaculum is already discussed in the tables. You also had a small group discussion of the same. So we will not talk about flexor retinaculum. I will assume that you already know everything that is to be known about the flexor retinaculum. It is a very important topic, so you should be thorough about the flexor retinaculum. So we will move on to the next, that is the palmar aponeurosis. So as soon as you remove the skin and the superficial fascia, you came across a fibrous triangular structure in the palm. That was the palmar aponeurosis. So it is a thickened central part of the deep fascia of the palm, and it is believed to be the degenerated tendon of the palmaris longus. You all remember the palmaris longus tendon which passed above the flexor retinaculum. Yes, it was one of the structures that passed above the flexor retinaculum. It is triangular in shape. So if you look at the diagram, you can see because it is a triangle, it has got an apex, it has got a base, it has got a medial border, and it has got a lateral border. The apex. The apex is directed towards the wrist, and it blends with the flexor retinaculum and the tendon of the palmaris longus from which it has originated. The base is directed downwards. Yes, not when you keep your hand, when you're looking at your hand, it will look the opposite. When I talk about directed downwards, I am talking about the hand when it is kept in the anatomical position. So when you keep the hand in the anatomical position, the base is directed downwards, opposite the heads of the metacarpal, and it is dividing into 4 slips, one for each of the medial 4 fingers. And each slip further divides into superficial and deep. The superficial longitudinal fibers blends with the dermis, which is a part of the skin. The deep longitudinal fibers splits into 2 slips, that is the medial and the lateral, that become continuous with the fibrous flexor sheaths of the corresponding fingers. The medial border is continuous with the deep fascia covering the muscles of the hypothenar eminence. Yes, medially you have the hypothenar eminence, right? So it is continuous with the deep fascia covering muscles of the hypothenar eminence. And it also gives rise to one muscle. All of you look carefully in the diagram, you can see one muscle arising from the medial border, and that muscle is the palmaris brevis. The lateral border, which eminence is on the lateral side? It is the thenar eminence. So it is continuous with the deep fascia covering the muscles of the thenar eminence. What is the function of this palmar aponeurosis? It is to protect the deeper structures during gripping, and it fixes the skin of the hand and improves grip. Now, I don't know how many of you have heard of this term or this condition, Dupuytren's contracture. What is Dupuytren's contracture? It is progressive fibrosis, thickening and shortening of the medial part of the palmar aponeurosis. So you have seen the palmar aponeurosis. Now look at your hand. Okay. Now imagine the medial part of this palmar aponeurosis being progressively getting fibrosed and thickened. And as it is getting fibrosed and thickened, it becomes shorter and shorter. So what will happen to your fingers? There will be flexion of the fingers because of the shortening of the medial side. It will be the ring finger and the little finger that will be affected. So the symptoms are permanent flexion of the proximal interphalangeal and metacarpophalangeal joints of the ring and the little finger, and the distal interphalangeal joint mostly remains unaffected. Why? Because the palmar aponeurosis is not extending up to that. Treatment is surgical fasciotomy and steroid injection. Now, there are certain septa that are arising from the palmar aponeurosis, that are going from the palmar aponeurosis to the metacarpals. These are called as the palmar septa. So how many metacarpals do you have? You have 5 metacarpals. So there are 3 septa. So you think of it as going to alternate metacarpals. So 1, 3 and 5. Okay. From the palmar aponeurosis to the 1st, 3rd and the 5th metacarpal. Okay. So first is lateral, 5th is medial, and the 3rd one is in the middle. Okay. So you will name the palmar septa accordingly. So from the lateral border of the palmar aponeurosis to the 1st metacarpal, you will call it as the lateral palmar septum. From the medial border of the palmar aponeurosis to the 5th metacarpal, you will call it as the medial palmar septum. And from the medial border itself, from the medial border of the palmar aponeurosis to the 3rd metacarpal, it is the intermediate palmar septum. Next, you have the fibrous flexor sheaths. The deep fascia in the fingers forms a fibrous sheath on the anterior surface of each finger. It extends from the head of the metacarpal to the base of the distal phalanx. Attachments. It arches and attaches to the sides of the phalanges. Proximally, it fuses with the palmar aponeurosis and gives entry to the long flexor tendons. Distally, it is closed and is attached to the base of the distal phalanx. It is thin over the interphalangeal joint. Why? If it is thick because where does the movement in the fingers take place? It takes place at the interphalangeal joints. So if it is thick at the interphalangeal joint, the movement will be restricted. So to permit movement, the fibrous flexor sheaths are thin over the interphalangeal joints. Now the pattern of fibers, if you look closely, it is having 2. An annular pattern and a cruciate pattern. Annular pattern, also called as the transverse pattern, and a cruciate pattern. This is to provide strength to the sheath to hold the long flexor tendons in position. That is why they are having this arrangement. So there is this fibrous flexor sheath, and beneath this the long tendons are passing. Okay, so what happens if there is a localized thickening of the long flexor tendon? There will be difficulty for it to move, right? Because this flexor sheath is an enclosed space and the flexor tendons are passing through it. Normally nothing is wrong. Okay, but if there is a localized thickening, what happens? The space is limited, it cannot move. Okay, so localized thickening of the long flexor tendons and the fibrous flexor sheaths restrict the movements of the thickened tendon, resulting in locking of finger in flexion. Okay, and the patient won't be able to extend the fingers, because when it has to extend, that thickening also should move, but that movement is not possible because of the fibrous flexor sheath. Okay, so treatment is either going in for a local steroid injection, and if that is not proving to be beneficial, you have to do a surgical excision of the fibrous flexor sheath. Now there is something called the Vincula longa and Vincula brevia. You must be familiar with these terms. Okay, they are slender tendinous bands that connect the long flexor tendons to the phalanges. So the flexor tendons are not simply going and attaching, okay, to the base of the phalanges. Okay, it is having connections, other connections in addition to its distal attachment. Okay, there are two types. They are called as the Vincula longa, which are long fibrous bands. If you look at the diagram, you can see those slender long bands. There is the Vincula longus. Okay, and the triangular, small triangular bands that you are seeing is called as the Vincula brevia. The function is to give passage to blood vessels to the tendons. Now we will come to the topic proper. Okay, that is the facial spaces of the palm. Now the facial spaces of the palm are divided into 5. They are the mid-palmar space, the thenar space, the pulp space of the fingers, the web space, and the forearm space of Parona. Mid-palmar space. Okay, all of you look at that diagram, orient yourselves. Can you see the hypothenar compartment? Did you identify the thenar compartment? Identify the metacarpals. Okay, the palmar septum. Yes, lateral, medial and the intermediate palmar septum. The palmar aponeurosis. Okay, all these you have identified. Okay, now we will go to the boundaries of the mid-palmar space. Anteriorly, keep your hand in the anatomical position. Okay, now you think and tell, or in your mind enumerate the structures that form the anterior boundary. They are the palmar aponeurosis, okay, superficial palmar arch. Then you have the flexor tendons of the little ring and middle fingers with their synovial sheaths, which is called as the ulnar bursa, which I will talk about a little later, and the medial 3 lumbrical muscles. So anteriorly you have the palmar aponeurosis, the superficial palmar arch, the flexor tendons, the long flexor tendons of the little ring and the middle fingers with their synovial sheaths, and the medial 3 lumbrical muscles. Behind what is there? The dense fascia covering the interossei and metacarpal bones of the 3rd and 4th spaces. Laterally what is there? You have the mid-palmar septum, and medially the hypothenar muscles separated by the medial palmar septum. I hope it is clear. The mid-palmar space, proximal and distal extent. Okay, proximally it extends up to the level of the distal margin of the flexor retinaculum, sometimes continuous with the space of Parona of the forearm, which we will discuss again later. Distally, it extends up to the level of the distal palmar crease, beyond which it communicates with the third and the fourth lumbricals. Okay, lumbrical canals. Sorry, it's not lumbricals, it is lumbrical canals. Now the applied aspect. So there can be collection of pus inside the mid-palmar space. So what will we do if there is pus collection? We have to drain it. If there is an abscess, if there is collection of pus, we have to drain the pus. So when we are draining the pus, we have to put an incision. So where will we put the incision? The incision, pus in the mid-palmar space, can be drained surgically by splitting the web between the third and fourth or the fourth and fifth digits and exploring the lumbrical canal. Thenar space. So in this diagram, you can see the mid-palmar space, and next to it you have the thenar space. The thenar space is triangular and lies on the radial side of the mid-palmar space. Anteriorly, again, look at the diagram and tell. You have anteriorly the palmar aponeurosis, the superficial palmar arch. It's not arc, I misspelled it, it is arch. Superficial palmar arch. Flexor tendons of the index finger covered with synovial sheath, that is the radial bursa. The flexor tendon of the index finger and the first lumbrical muscle. Posteriorly, deep layer of the deep fascia covering the adductor pollicis. Laterally, you have the lateral palmar septum and medially the mid-palmar septum. Proximally, the thenar space extends up to the level of the distal margin of the flexor retinaculum, and distally, the space extends up to the level of the distal palmar crease, beyond which it communicates with the first lumbrical canal. Now, we have mentioned a radial bursa and an ulnar bursa. Okay, so what are these? So they are synovial sheaths. So there are three synovial sheaths that you should be familiar with when we talk about the palm. They are separate from the palmar space. Okay, the synovial sheaths are structures that are enclosing the flexor tendons or the muscles, not the muscles, the tendons. Okay, so you have two bursae, that is the radial bursa, the ulnar bursa, and the digital synovial sheaths. So let us look at these structures and their relation with the palmar spaces. Now look at the diagram. All of you identified the radial bursa. Okay, so the radial bursa is a synovial sheath surrounding the flexor pollicis longus tendon. Okay, synovial sheath surrounding the flexor pollicis longus tendon. It extends from the forearm 2 centimeters proximal to the proximal margin of the flexor retinaculum to level of base of the terminal phalanx of the thumb. It is closely related to the thenar space and it is continuous with the digital synovial sheath of the thumb. The ulnar bursa, all of you look at the diagram again. Can you see the ulnar bursa? Yes? Okay. So it is a common synovial sheath surrounding the tendons of the flexor digitorum superficialis and the profundus. Extends again from the forearm 2 centimeters proximal to the proximal margin of the flexor retinaculum up to the mid-palm level. It ends as a cul-de-sac. What does cul-de-sac means? A blind pouch or a blind ending. Okay, so it ends as a blind end but retains continuity with the digital sheath around the flexor tendons of the little finger. And it is closely related to which space? In this area, which space is coming? You have the mid-palmar space. So radial bursa is related to the Thenar space and the ulnar bursa is related to the mid-palmar space. Now look at this diagram. All of you again identify the ulnar bursa and the radial bursa. Okay, all of you have identified. Now, so what is this digital synovial sheath? From the name itself, digits. Okay, so synovial sheath in the tendons, flexor tendons in the digits. So encloses the long flexor tendons during their passage deep to the fibrous flexor sheaths of the fingers to decrease friction. Extend proximally up to the head of the metacarpals and distal up to the distal phalanges of the digits. Continuity, thumb with the radial bursa and the little finger is continuous with the ulnar bursa, as you have already seen in the previous slides. Function, to allow smooth frictionless movement of the long flexor tendons through the osteofibrous tunnels. So applied aspects, as you have already mentioned, earlier we said trigger finger, okay, that is localized thickening of the tendon. Now if instead of the tendon being involved, if the synovial sheath is involved, okay, same effect, that is flexion of the fingers, inability to extend, all these will be there, but the pathology is different. Okay, there it was the tendon that had a localized swelling. Here it is the synovial sheath that is inflamed. So when the synovial sheath is inflamed, it is called as tenosynovitis. And this tenosynovitis, if it is involving the little finger, what happens is it can infect the ulnar bursa, because you saw of the little finger it is continuous with the ulnar bursa. So from the ulnar bursa, which space can it go to, or which space is it communicating with? It is communicating with the mid-palmar space. Similarly, if the tenosynovitis of the thumb can infect the radial bursa, and this inflamed radial bursa can burst into the thenar space, causing abscess. Okay, so this is the applied aspect. Okay, now I mentioned lumbrical canals earlier when we talked about the mid-palmar space and the thenar space. Yes, second and third and fourth and the first lumbrical canals. Now what are these lumbrical canals? They are spaces around the lumbrical muscles. The mid-palmar space communicates with the third and fourth web spaces via the lumbrical canals, whereas the thenar space communicates with the first web space via the first lumbrical canal. Hence, the first web space is incised to open the first lumbrical canal to let out the pus. Proximal ends of the digital synovial sheaths of the index, middle and ring fingers extend to the distal limits of the mid-palmar and the thenar spaces. Now the next space that is important is the pulp space. So what is this pulp space? Can you feel the tip of your fingers? Very soft. That is called as the pulp of your fingers. Yes. Okay, now the space that is seen in the pulp of your fingers is called as the pulp space. So the space which intervenes between the palmar skin and the distal phalanges of all the digits, and it lies distal to the fibrous sheaths of the flexor tendons. In each pulp space, the skin is connected to the periosteum of the distal phalanx by numerous radiating fibrous septa. Can you see the diagram? Can you see radiating septa? The skin and the periosteum, they are connected by radiating fibrous septa. It subdivides the space into tight compartments containing subcutaneous fat and blood vessels. Now, if you look closely at that diagram, you can see that the distal 4/5 of the distal phalanx, the blood supply from the digital arteries, it penetrates the dense fibrous septa. Yes. So you can see one dense fibrous septa, and after that it is supplying. Once the blood vessel has pierced that, it is going and supplying the 4/5. What about the proximal 1/5? It is having a separate blood supply. It does not traverse the septa. Now, why is this important? Now, can you see this finger? Can you see the reddish discoloration? Painful looking, tender looking fingertip? Yes, that is called as vitiligo. It is infection of the pulp space. Severe throbbing pain. Why throbbing pain? Because of the fibrous septa, the skin and the periosteum are connected. Yes, so there is not much space for any collection to expand. So whatever is there has to be enclosed in that tight fascial compartment. So the pain will be of a throbbing nature. The treatment is lateral incision, opening up all the interseptal compartments without damaging the sensitive skin of the pulp. In neglected cases, there is avascular necrosis of the distal 4/5 of the terminal phalanx. Okay, that is the one that has crossed the septa and is supplying. But the proximal 1/5, which is having a separate blood supply, remains unaffected. The next space, the web space. They are 4 in number. Subcutaneous spaces within folds of skin connecting the bases of proximal phalanges. It extends from the free margin to the level of the metacarpophalangeal joint. All of you see in your own hands, from the free margin to the level of the metacarpophalangeal joint. It contains subcutaneous fat, superficial transverse metacarpal ligament, the tendon of the interossei and the lumbricals, and the digital nerves and vessels. The last one is the forearm space or the space of Parona. Even though it is a forearm space, it is included here because of its continuity with the Palmar spaces behind the flexor tendons through the carpal tunnels. Boundaries. Anteriorly, long flexor tendons wrapped in synovial sheath. Posteriorly, the pronator quadratus muscle. Very rarely, this space is filled with pus if the inflamed radial or ulnar bursa bursts here. So that is all about Palmar spaces. Thank you.